Hello and welcome to RPTH Research Recaps, where we dive a little bit deeper into the science being published at RPTH. My name is Cihan Ai. I'm working at the Medical University of Vienna in Austria, and I'm the deputy editor of RPTH. I'm pleased to introduce the presenter of today, Tessa Noordemeyer. Tessa Noordemeyer is a PhD student at the Van Creveld Clinic at the University Medical Center Utrecht in the Netherlands. Within her PhD, she's doing clinical and fundamental research on thrombosis within the topic of antiphospholipid syndrome. She recently published her paper in RPTH titled Interference in Point-of-Care International Normalized Ratio INR monitoring in patients with lupus anticoagulant is correlated with anti-beta-2 glycoprotein 1 antibody titers. This paper has received attention of the editor team and also on Twitter, as we believe that it is of clinical relevance. And for those joining us live on Facebook, Twitter, and YouTube, please leave your comments below, which will be answered during the discussion. Dr. Noordemeyer, we look forward to hearing your presentation.
Thank you for this kind introduction. It's a great honor to present here in one of the RPTH Research Recap presentation. And within this presentation, I will talk about the manuscript that is recently published in RPTH, which is about the interference of lupus anticoagulant in INR monitoring in patients with the antiphospholipid syndrome. The antiphospholipid syndrome is an autoimmune disease in which patients have thrombotic events or pregnancy-related complications in combination with the persistent presence of antiphospholipid antibodies. Of the clinical symptoms, most patients experience venous thrombosis, and to prevent the risk of recurrent thrombotic events, patients receive oral anticoagulant therapy, and most APS patients use vitamin K antagonists. The use of vitamin K antagonist requires strict monitoring to prevent the risk of bleedings, and this monitoring can be done with the International Normalized Ratio, so the INR. And the optimal therapeutic window for the INR for vitamin K antagonist is usually an INR between the 2.0 and 3.0. And to make sure that this INR falls within this correct range, patients have to measure their INR frequently. And this measuring can be done either in a diagnostic lab using the Orange method or the Quick method. And these assays are based on the prothrombin time and make use of a venous blood sample. But patients can also choose to monitor the INR themselves using a point-of-care test, such as the CoaguCheck XS. And most patients choose to use such a point-of-care device since the INR must be measured frequently and they can do it at home in this way. The problem is, however, that some antiphospholipid antibodies known as lupus anticoagulant can interfere with phospholipid-dependent coagulation assays. And the presence of lupus anticoagulant can lead to a prolongation of the prothrombin time, leading to falsely elevated INR values. And it's known that especially that lupus anticoagulant especially interferes in those point-of-care tests, while lupus anticoagulant doesn't really interfere in most laboratory assays. And this difference in interference is thought to be dependent on the type of thromboplastin reagents that are used, and also the dilution factor of the plasma plays an important role. For the patients, it's of course really important to have correct INR values since they use the INR to adapt the VKA dosage, and falsely elevated INR values results in a lower dosage of VKAs, and this can increase the risk for thrombotic events. The aim of this study was to investigate whether INR values measured with a point-of-care test differ from INR values measured within the lab. And we did this in lupus anticoagulant positive APS patients that were all using vitamin K antagonists. And in addition to this, we wanted to investigate which antiphospholipid antibodies correlated with the observed discrepancies. To investigate this, we designed a single-center cross-sectional study in which we included thrombotic APS patients that were all positive for lupus anticoagulant and used VKAs for a minimum of 3 months. For every single patient, we determined the INR in 3 different ways, and we performed this all on the same day. And we did 1 point of care test, which is the CoaguCheck XS, and we measured the INR with 2 laboratory assays, which are the Owens method and the Quick method. For all patients, we also confirmed the lupus anticoagulant positivity using a DRVVT and LA-sensitive APTT, and we measured quantitative values of antiphospholipid, IgG and IgM antibodies, and therefore we detected anticardiolipin antibodies, anti-beta-2 glycoprotein-1 antibodies, and anti-PSPT antibodies. Then to the results of this study, we included a total of 33 patients, and here in this table you can see the demographic and clinical characteristics. If you take a look on the right side of this table, you can see the antiphospholipid antibody profiles, and you can see that a lot of patients have anti-beta-2 IgG antibodies, and also a lot of patients have IgG or IgM antibodies towards these PSPT complexes. And here you can see the median INR values of the 3 different assays we did. And as you can see, the point of care test INR is slightly higher than the 2 laboratory INRs. And to visualize the actual correlation between the assays, we used scatter plots. As you can see, the overall correlation is actually quite good, but you can see when the INR values increases that the differences become larger between the assays. And to evaluate the actual agreement between the assays, we used Lin's concordance correlation coefficient, and this method is based on the fact that if there is perfect agreement, the regression line will be a 45-degree line through the origin, so which is shown here as the dashed line. Now, if you then take a look at the graph showing the quick INR compared with the Owen INR, you can see that the actual agreement is quite good. And this is also reflected by the relatively high correlation coefficient. But if you compare the point of care test INR with the 2 laboratory INRs, you can see that the agreement is less. And this is also reflected in the relatively low correlation coefficients. We also evaluated the correlation between the assays using a Blunt-Altman plot. And here on the y-axis, you can see the relative differences between the assays. And we use the agreement limits described by the Clinical and Laboratory Standards Institute, which are set to 20%. So if the INR difference is less than 20%, it's seen as okay. And if it's more than 20%, it's seen as a disagreement between the assays. Now you can see that for most patients, the INR difference is less than 20%. But if you compare the point of care INR with the Owen INR, you can see that relatively more patients have an INR difference more than 20%. Now, next, we evaluated which antiphospholipid antibodies correspond to the INR differences we see. And therefore, we divided the patients into 2 different groups. So we have the group over here consisting of patients who had an INR difference less than 20%, so that were labeled as INR agreement. And we have the patients with an INR difference more than 20%, so that are the patients with INR disagreement. And here you can see the different antiphospholipid antibody assays we did. And if you then take a look at the lupus anticoagulant ratio determined with the DRVVT, you can see that this ratio is actually higher in patients with an INR disagreement. We also see higher anti-beta-2 glycoprotein-1 IgG antibodies in patients with an INR disagreement, and also see higher APSPT IgG and anticardiolipin IgG antibodies. In the end, we also investigated the correlation of the antiphospholipid antibodies with the INR differences, and of all antiphospholipid antibodies, the anti-beta-2 IgG antibodies correlated best with the INR differences we saw. So to conclude, we found disagreement of INR values measured with the point-of-care test compared to INR values measured in the lab in a proportion of lupus anticoagulant positive APS patients. And therefore, we recommend to use laboratory INR monitoring over a point-of-care test INR monitoring in lupus anticoagulant patients, and specifically in patients that either have high anti-beta-2 IgG antibody titers or have a point-of-care test INR that is above the 3.0. And with that, I would like to end this presentation. I would like to thank the people that are listed over here who all collaborated in this study. And of course, I would like to thank Gian for organizing this session.
Yeah, thank you so much, Tessa, for really such a great presentation. And also thank you for conducting this work, which I think is very practical. So I have a couple of questions for you, and maybe we start with the first one. You have used different assays and tests for INR monitoring, which you mentioned, INR point-of-care tests, lab INR based on quick and overrun method. Can you explain us a little bit the differences between these assays?
Yes, of course. Thank you for this question. Yes, we make use of 3 different assays, so 2 laboratory tests and 1 point-of-care test. And these assays are all different in the type of thromboplastin reagent that they use, and also the kind of dilution factor of the plasma. So, for example, the Owens method, this assay is seen as the golden standard for INR monitoring. And this assay makes use of a more like a conventional thromboplastin reagent, and the dilution factor of this of the plasma in this assay is really high, so you have less interference of lupus anticoagulant. Well, if you compare it with the quick method or the point-of-care test, these assays make use of a recombinant thromboplastin reagent, and these reagents are known to be more susceptible for example, lupus anticoagulant interference, but also for more like in the initial phase of VKA treatment, the INR is unstable, and that is also reflected when you use recombinant thromboplastin reagents. And then the dilution factor of plasma is also less in this quick method of assay, and also in the point-of-care test, there is no dilution at all. So you have a high influence of lupus anticoagulant in this assay.
Well, thank you so much for explaining these details and the differences. I learned a lot. I have another question for you. I mean, as I mentioned, it's a very important and clinically relevant finding that you are reporting. What are the implications of your findings for patients with the antiphospholipid syndrome? Is there something you can suggest in terms of INR monitoring these patients in clinical practice?
Yeah, that's a really important question indeed. And so first of all, we advise to use laboratory monitoring in patients that are lupus anticoagulant positive, or do at least a comparison of the INR with within the lab compared to the point-of-care test when you start with point-of-care or want to start with point-of-care testing to see if it's comparable. And patients that have lupus anticoagulant and high anti-beta-2 IgG titers, yeah, therefore we wouldn't really advise to use the point-of-care test anymore. So for them, it's better to measure the INR in the lab.
So that's not a good news for patients who are lupus anticoagulant positive. So they should, yeah, thank you so much.
Yeah, but it's really important, yeah, for them to know.
Yeah, that's a great discussion. Thank you for the great discussion, and also the great presentation again, and giving us also more insight into this topic of discrepancies between point-of-care INR and laboratory INR in patients who are lupus anticoagulant positive. on vitamin K antagonist, I think this is important because this is the therapy of choice that is suggested for these patients. So we are coming to the end of our RPTH Research Recap. Thank you for all of you watching and joining, for those joining us live. And don't forget to follow us on Facebook, Twitter, and YouTube. And thank you all again for watching, and keep an eye out for the next RPTH recap.